Good evening, everyone. Welcome to our webinar. My name is Majid Seyhani. I'm a General Director of Risk Compliance and Governance at Saudi Risk Crescent Authority, and I will be serving you today as a moderator. You will be hearing a presentation today from Mrs. Shurooq Zakaria. She will be speaking to us on transforming into a risk-aware culture. Ms. Shurooq Zakaria is the Director of Risk Management Division, headquarters at King Faisal Specialist Hospital and Research Center in Riyadh, with over 22 years of experience in quality and patient safety. She obtained her bachelor in nursing from King Abdulaziz University in Jeddah. She holds a master degree in healthcare risk management from University College London in the United Kingdom. She is certified professional in patient safety and certified professional in also healthcare quality, who also has completed her patient safety leadership fellowship from American Health Association and National Patient Safety in the USA. Last but not least, Ms. Shurooq led several initiatives such as Zero Harm Initiative at King Faisal Hospital, Jeddah for 3 years. In addition, she's been involved in several national conference, workshop, and training, covering quality, patient safety, KPIs, Lean Six Sigma, and disclosure and second victims. Now moving along to our session, please welcome Mrs. Shurooq Zakaria to deliver the presentation on this very timely subject.
Thank you, Dr. Majid. Well, without further ado, let me just let you know what exactly we're going to cover today. First, I will talk about the evolution of science of enterprise risk management. That's the focus of today's session. We'll be covering everything related to enterprise risk management, especially the fact that everybody's focusing on that nowadays, especially with the transformation. We'll be talking, of course, on the benefits. If I have any evidence, I'll be sharing it with you as well. How to measure the maturity in the context of risk management, understanding our roles. I know a lot of people are asking about defining the roles of each employee, each manager in the hospital, executives and board members as well. We'll be covering that as well. Breaking down risk management jargon. We'll talk about the language itself, because one of our goals is to make risk management a common language among all. We'll be talking about predictive analytics, specifically about the KRIs. This is because we know that a lot of people get confused between the KRIs and KPIs, and especially for risk management, it's important to understand the KRIs. I'll leave you with a takeaway message, and I really hope that the time will be enough for us to cover everything. For the history, I know some of you, especially those who are certified professional healthcare risk management, know a bit of this, if not everything. So I'll be quick in going through the history. Risk management is not something new. It was there since the 1800s. It started with the risk management principles. It was there since early China, and that there are lots of evidence that when they, for the merchants, they used to divide the cargoes among the ships. God forbid if anything happened to one ship, for any kind of incident, they would not lose everything. So that was a sort of risk management. Another evidence similar to that also was there in London. For the clinical risk management, there were lots of beginning in the epidemiology, especially if you go to 1854 with Dr. Snow, he tried to link the cholera with the contaminated water. During the pandemic, same thing with Dr. Semmelweis in the 1847, where he linked the hand hygiene to decrease incidence of fever and infections. So that was also one of an evidence for clinical risk management. After that, in the 1950s, that's the time where people started realizing that the cost of insurance is huge and the extent of the coverage was limited. So the amount they're paying for the insurance is more than what they were covering. So what they did, the organizations, including healthcare, what they did is that they tried to look at what they can do on their own in order to minimize the number of the premiums or the amount of money they're paying for the insurance. So that's, you can call it risk management. That's in the 1950s. After that, if we're looking at the 1960s and 70s, that's the first time we hear about risk management under the occupational health and safety practitioners. So they're considered pioneers in the field. That's between 1960s and 70s. In the 1980s, the application of risk management techniques started with project management around that time. And after that, in the 1990s and 2000s, you'll have a lot of evidence of risk management. The first time we hear about corporate governance, ERM, the first appointment of the chief risk officer, that was around that period. And now I know this is the brief, but I know a lot of people will ask, okay, why the sudden interest of risk management or enterprise risk management, to be specific? Started in 2008. What happened that time, I'm not going to cover it. It's not in the scope of this session, but there are lots of movies that talk about the financial crisis that happened back in 2008. You can go and watch it if you would like to learn more about it. But what happened is that it put risk management under the scope. A lot of people started questioning, after all this talk about risk management, how come it did not work? Especially in the financial world, they were using the risk management tools. So how come it didn't work? And then they started having a lot of publication. And if you read about it, you find out it was not about the tools. It was about the application, the people buy-in. Because of that, you'll find a lot of studies. And even if you look at any job description for risk officer, chief risk officer, director, you will find out one of his objectives is to instill or develop a risk-aware culture. Because if you don't have that, you cannot have risk management. The buy-in is very important. And that's why if you're interested in applying ERM or having a robust risk management program in your hospital, you need to have the buy-in from the people. And if you want to have a risk-aware culture, you need to make sure that what you cover is not only introduction, but you need to cover the obstacles that we're facing and how they can avoid them. And I'm going to summarize here for you a few points that some of you might find it difficult, but during the session, I will be elaborating on every single point of them. So let's talk about the first point, quantify. If you want to have a risk-aware culture, usually a risk-aware culture seeks to what? It seeks to, 1, quantify potential variability to inputs and outputs when evaluating and prioritizing competing projects, initiatives, and strategic directions. A lot of people might say, yeah, Shuruk, we do have that. We do quantify potential variability. Believe me, we're not there yet. Until now, I meet with a lot of people and I found that in order to prove to, especially in meetings when you try to push for your project, I hear a lot the term, oh, it's impacting patient safety, give it a priority. This is not enough. And this is can be really deceiving sometimes. You're putting the leaders in a really difficult position. Everything we do in the hospital is somehow impacting patient safety. So you cannot use that. And it's not enough alone. So you need to quantify if it's really impacting patient safety, how? If I didn't implement your project, does that mean we're going to lose patient lives? Or maybe just their own experience? Maybe they're willing to take that risk. You never know. Another approach is, but sometimes people say, oh, this is a project, for example, or this thing is very important, we need to have it, is because it's impacting accreditation. It's not enough. You have to make it clear to whoever you're presenting to or you're giving your proposal to that if it's impacting accreditation, how? Are we going to lose the accreditation? Or maybe we can get out of it with partial remit. And leave that decision with the leaders to decide. Because in risk management, our role is to provide them with all the details so they can make, the leaders of the hospital, they can make informed decision. How? With quantifying our details. So these are just two examples of the common things that people say, this we do quantify it, but in reality, we tend to not quantify a lot of things. And even with the risk management, I will show you later on that when they put the details of the risk, they don't quantify the impact. If you have the details, if you have how much it's gonna cost the hospital if this risk happened, put it in. And I found that people sometimes, no, I don't have it, but you can calculate it, go and calculate it and come back again. We don't have that culture yet in healthcare. Another thing is in identifying the sources such as KRIs. People don't put KRIs. Actually, they don't even understand some of them. They don't understand the difference between KRIs and KPIs. Until now, I'm facing people who put KPIs and tell me, okay, Shuruk, this is my KPIs. And just because they are, let's say they're working risk management, so every KPI they have, they just change the name to KRI. That's not how it works. And I'm going to explain to you how it should be done. Measure the anticipated consequences to such variability, both positive and negative. We tend to focus on negative risks only. So risk to us are threats and something negative. We never looked at risk as an opportunity or something positive. So that's something we can start working on. But if you're not having a program, don't push for it. You have to start by embedding the culture first and making people understand. Maybe you can start with the negative, educate them about identifying opportunities, and with time, once they feel involved, once they see the fruits of applying the risk management, they will come to you and tell you the positives. Develop mitigation strategies to lessen the impact and or reduce the likelihood of negative consequences. Yes, and I know that if you're dealt with quality management, or if you're in patient safety and quality management, you're aware of action plans. In our language and risk management, we call it mitigation plan. That's the mitigation strategy or mitigation plan. That's the only difference. But the way we deal with them, the way we prioritize our action are the same. And I'm going to cover that in today's lecture as well. Last, develop contingency plans to deal with negative consequences if mitigation strategies fail or are not available. Try to be proactive. And it's not about just reporting risk and adding that into your risk register. It's about you being ready to face that risk if it manifested. So usually if somebody just completed the risk register with all the information about the risk, a simple question that you can ask, if God forbid that risk manifested tomorrow, happened, if that risk happened today or tomorrow, are we ready? I think this is the easiest way to see whether that team or the hospital is ready or not. Okay, I have a question for you. I don't know how I'm going to put it in. I want to ask you a question, which will open a lot of discussion after that. I want to see whether you got the message or not from what I said until now. Which of these logos you see here expresses a weak culture towards risk? Is it Kodak, Apple, Virgin, or Nokia? You're going to open the poll. I don't know how they're going to planning to give me the answer.
I think, Mrs. Shuruk, if they have an answer, they just raise their hand or write it in the chat.
Okay, if that's the case, no problem. It's just about, I want you to just think about it. I want to see whether most of you have got the message and understand it or not. Can you see it from your side? Dr. Majid?
Yes, there is an answer in the chat. Kodak, they wrote Kodak number 4.
Kodak, yes.
Someone write Nokia.
Nokia. Anyone said Apple or Virgin?
No one say Virgin or Apple.
Tamam. I think you got the message. The reason why I added this question is because yes, it's well known. If you read about these 4 companies, you'll see that culture is very important for your success. And you can see here Kodak have the worst history, to be honest with you. One fun fact for you. Do you know that the person who invented the digital camera was an employee in Kodak? If not, then the fun fact is that yes, he was an employee, and they rejected his proposal when he came up with the idea of coming up with a digital camera. They rejected his idea, so he had to go, of course, somewhere else to prove himself. So the point is, I want you all to understand that culture is very important if you want to apply anything. Now let's go to the second point, which is enterprise risk management. People usually ask me, okay, but Shuru, we do have, especially in healthcare, we do have clinical risk. What's the difference then? The only thing is it's not a new division. It's not a new department. I don't want you to understand it like that. Enterprise risk management is a process. It's just that it's not only the clinical risk. You cover every single division department in the hospital. So you're not only looking at the clinical risk through the reporting system or through the sentinel events or the other ways we know in quality management, but we also conduct risk assessment, the whole process in all division in the hospital, all departments like human capital, supply chain, academic and training affairs, what else? Every single divisions, all the support services. So every single corner in the hospital must be covered, whether it's clinical, non-clinical, impacting patient, impacting visitors, impacting employees. Everything should be covered under one umbrella, under one risk register. It is designed to identify potential events that may affect the entity, the hospital, and manage risk to be within its risk appetite. So we're going to take the clinical risk management to the second level, especially those who did not yet. Right now, based on what I'm dealing with in the Saudi hospital, the requirements for clinical risk are the minimum requirements from JCI and CBAHI. You need to have a reporting system in place. You need to have a policy for sentinel event. You need to have focusing on near misses, the FMEA, and so on. But they don't take you through the whole loop. So they don't require having a comprehensive risk register, for example, for the whole hospital. They don't have specific criteria for, they don't require you getting involved in the development or in approving the insurance program for the hospital, for example. They don't require you to get involved in the medical legal and see what's the status of the hospital. You don't have a risk appetite. It's not a requirement. So these are, if you studied risk management, you'll know that these are the full cycle for, or the framework for risk management. To provide reasonable assurance regarding the achievement of entity objectives. So the goal is I can go to the board or the higher management with one risk register, which is a complete document that have all the risk in the hospital, regardless of its impact, and making them making informed decisions based on the all the risk that they see. Now, this is from ASHRM, the American Society for Healthcare Risk Management. If you really want to know more about risk management, clinical risk management, and even ERM, you can find that as a clinical person in the ERM. I'm going to refer to other sources for non-clinical people, if any, attending with us today. So I chose this one because it's I think the simplest way to look at the differences between the traditional way of risk management that we used to do is the clinical risk management in healthcare and the ERM, the enterprise risk management. Previously, mostly it was reactive. It's pushed you more to be more proactive in the enterprise risk management. But that's not the main thing, because I know that because of the high reliable organization concepts that a lot of hospitals adopted, some of you might say, but we already started to be more and more proactive. Number two is also a common reason for why people adopting ERM is because of value creation, because they're not looking at risk as something negative like before. They're looking at it as a value creation opportunity. The way we look at risk is different right now. And I'm going to touch on that more later on. ERM is enterprise-wide, so it's not only specific departments or divisions or clinical versus non-clinical. We call it risk mitigation before it's risk response. So instead of using the term action plan for risks, for incidents, now we call it risk mitigation. For the ERM, and this is important, and as an example for King Faisal, it came from top down. It's important for the success of the program. I've seen it in different hospitals with different level of success, depending on the involvement of the higher management, of course, which is exactly what we teach people in quality management. If you get the involvement or the green light from the leaders, it is so easy for you to achieve your goal. Why board members care about ERM? They have a lot of reasons, but the one I want to focus on today is this. Is it linked to the transformation that's happening in the kingdom? Yes, if you look at objective number 3, promoting prevention of health risks. That's why a lot of board members, a lot of executives in different hospitals are creating or focusing on risk management in the hospital. So if you're wondering why the sudden focus, if they started in your hospital, this is it. This is just to make you feel better. I don't want you to think that's impossible to implement or we're behind. This is a study that was done according, sorry, this is a repetition, to a new productivity report that was published last year. Less than 10% of Middle East companies have mastered enterprise risk. And that's not healthcare, by the way. So if they started years ago and still less than 10% of Middle East companies did not master the enterprise. So we have a long way ahead of us. I'm going to give you another, I'm sure that you'll be asking, okay, how many years do we need to accomplish this? I'm going to talk about that. Also, you'll find a lot of people asking you about the benefits. Yeah, I don't want you to say, oh, patient safety, oh, it's important for the image of the hospital. No, remember we said value creation? Value creation means money. Now everybody talks about money. So here I brought for you one evidence. There is a correlation between risk management maturity and business success. We can look at everything we do as business now. So this was a study published, I think, years ago. But anyway, it shows here, I forgot the reference name, but I gave you the link so you can go and check the link of who are the authors of this publication. Companies in the top 20% of risk maturity generated 3 times the level of EBITDA as those in the bottom 20%. If you don't know what EBITDA means, it's earning before interest, before taxes, before depreciation, and so on. So this is important, but it's also important for you that the financial performance is also highly connected to the level of maturity. What maturity is the integration or correlation across risk, control, and compliance functions. So that's based on evidence. People ask also about the perfect framework. Shall we use a specific framework? No, I don't advise you to, I'm not with advising people to go ahead using one framework. I know for the transformation, they're using COSO, if I'm not mistaken. There are lots of other references I will refer to in this presentation, but every hospital, that's why I call this slide the perfect fit. You need to test what suits your hospital. Unless you are obligated to follow one framework, that's another story. If not, you may choose something that everybody agrees on the definitions, the details, and then you can go on. The processes, usually when we say framework, we're referring to the matrix, we're referring to the processes, risk identification, evaluation, assessment, response, and so on. The rules and responsibilities, all the details are covered under the framework. The risk management process cannot take place in isolation. It needs to be supported by a framework. We agreed on that. The transition to an ERM framework in healthcare is becoming more and more common and is clearly necessary. The ERM framework in place in each organization will differ, expected, unless your organization have to follow something mandated by the government or another body, but certain key themes will be present in successful implementation, of course. You'll find that most of if you read about more and more about the different themes that are available online, you'll find that they all have a lot of things in common. Maybe the language is different. For the clinical people, we're used to ASHRM. They're using COSO, and usually the Americans, the language is simpler. But for ISO, for example, for other modules, and I noticed that the language is with the Europeans more dry, if I shall say. So yeah, you might find it not easy to read, and you might read it more than once until you get the message. But in general, the concept is the same. For risk management standards, and this slide is very important for your information. Remember, I talked about the different models. ISO 31000, very common. IRM is another one for Institute of Risk Management. The COSO, the COCO, the one used in Canada. Why is it so important? I'm not giving you this just only for your knowledge if you want to read, but because especially us as clinical people, we tend to clash with the people who studied risk other than COSO or not ASHRM. You'll find that as if they're speaking another language, they're aliens to you. You need time until you get it. So if you get familiar with these standards, you'll find yourself, we're aiming towards the same thing. It's just that the language might be different. So some of you, so be tolerant and educate yourself. So if you found somebody, especially, for example, engineering, for example, they don't study COSO. Most of them are ISO, safety, security, same thing. Supply chain, maybe IRM or ISO, also the same thing. Depends on what certificate they get. So if they're IRM, you find them mixed. But in general, if you get familiar with the terms, you'll know how to respond to them. You know that they're not asking for something that you're not doing or against your framework. It's just simply different words. So you know how to respond to them. Again, it's about increasing awareness. Is there a time frame for ARM implementation? There is no single action that will ensure adequate implementation and no single time frame for the implementation, but your experience will make the difference. The support from the leaders, if it's coming from the top, will make the difference. They say it takes between 2 to 5, but believe me, I'm sure it will take more time, especially if you're taking your time and there is no mandate. And you want things to be successful and you want the buy-in from the people, it might take more than that. But your experience, it makes all the difference. So if, for example, taken every year and evaluate yourself at the end of the year and correct certain things every year. So don't introduce a lot of changes every year. Before the end of the year, maybe, for example, okay, we'll say the following year, for example, we'll introduce this and this. You'll find that the gradual implementation helps people, especially that for the risk management, by the way, you tend to deal with a lot of people from other departments who are not full-timers like you if you are working fully in quality management or patient safety. So if that's the case, you might find resistance if you implement a lot of things in the same time. Now, my question, ask yourself this, is your role in risk management clear to you? Whether you are attending with us today, you're just an employee who's interested in this topic, or you're working in quality and patient safety, or you're a director, or you are an executive, or just anyone in the organization. So do you know what's your role? If yes or no. Tell me what they say.
Thank you, Mrs. Shuruk. You can write it in the chat. Also, if you have a question, I saw someone raise his hand. So if you have a question, please kindly put it in the Q&A and write your question there. Around yes, all of the answers is yes.
Oh, great. That would make it easy.
Someone write no.
Okay. I think this summarizes everything. But for the employees, of course, you can see here, most of their role is just to implement. We have here 1 PEEP to participate for the risk assessment. The risk assessment is usually conducted on a yearly basis at the beginning of the year. I'll be touching on that later on. So you really advise a lot of people to attend the session with you. So every single voice count. So the frontline staff who knows most about the problems and what's really happening on the floor can be really trigger a lot of good questions for identifying risk in their areas. We can see only one for D, develop, which is risk education. So they can help in the development of the program or reviewing the content at least. So you can get some feedback from them before launching your educational program. Listening to people in general really helps you because you might sound easy for you, but they will tell you no, but can you elaborate more, for example, on these points because nobody knows about it. You think they know, but they don't. You can see here the role of the chief risk officer. The working group are the people usually who are doing the work. In our hospitals, you may refer to them as risk officers, who are people who are appointed in every division to complete the risk register in their areas, compile it for you, educate on your behalf in their areas, come back to you with any challenges, and you meet with them frequently. Or the committees, for example, subcommittees maybe. You also need to have a steering committee in place. You see the senior leadership, they also play a role, and the board. The board, it's very important to understand that they are the one who develop, implement, and review, evaluate, and approve the strategy. The risk appetite is not you or quality management or patient safety who put it. It needs to be the higher management, the highest level of your management in your area. The risk assessment, response monitoring, evaluation, and risk communication. For participation in risk education, yes, because it gives, it shows the involvement of the leaders. So, and we've seen it when they are involved in the education, you see more and more people are interested in attending the sessions and participation and in their participation as well. The steering committee, that's where you discuss the challenges, you show the what you have achieved so far, how many risks you have, what's the status of each. And we're going to touch later on about the next steps after that. It's not only about having a risk register in place. Remember when we said the ultimate goal is to help them making decisions. So who are they? It's the board, or if it's delegated to the committee or the chief risk officer, they will make certain decisions of what are we going to do with these risks? Are we going to accept them? So we're gonna self-insure them, or are we gonna transfer them, or we're gonna continue supporting them to mitigate the risk? That's the decision. Otherwise, just completing a document and submitting. If that's the case in your hospital, that's not risk management. You're just not there yet. I added for you, but because of the time, I won't be able to go through them all. I added for you more than one reference on how to measure where you stand right now. And this is one example of how to measure the maturity of the level of risk management in your area. Enterprise risk management, I should say. So you'll see that this is the basic, this is the intermediate, this is the advanced. So if you already started compiling the use of data for decision making, you're on the right track. And then when I say decision making, I'm not talking about one or a few risks from the risk register. I'm talking about reviewing every risk in order to make informed decisions, and the board or the executives aware of which risk we should support to mitigate those risks and give it a priority, which ones I think it's time to transfer it to insurance company, for example. Developing an understanding of ERM, that's when you find everyone started to develop an understanding of the ERM, using ERM strategies and tools for key risk on unit, department, and basis. Understanding better the correlation of risk, which is something I'm going to cover for you later on. Moving to value creation. If you started moving to value creation, so it's not only looking at the negative, but the positive as well, the opportunities, and then you can say that you're intermediate. Other than that, you're still here. It depends, طبعا. If you're finding yourself on most of them. So you're only missing one, for example, identifying risk opportunities, or not there yet when it comes to micro ARM for every single area. Then you can say yes if you're getting most of them. So you can say yes, I'm intermediate, moving towards advanced. So just for the sake of time, you can see here that sometimes organizations have a mixture of all. So try your best to be focused. So in order, if you're, and to be realistic as well. So don't jump to advanced. If you're still in the basic, make sure that you fulfill everything before you move on to the intermediate. For the basic, it's compartmentalized risk program. So you can see that the focus on certain departments or divisions. Asset preservation, which means that you're focusing on a protection for the asset of the hospital, protection from fire, protection from patient falls, protection from certain things like that. Value protection, risk identification is reactive. If mostly reactive, then they're still in the basic. Inconsistency in risk management practices between divisions or departments. If you found that some divisions are much better than the others, you're not there yet. If you're mainly traditional, the clinical risk, it means that you're still basic. Focus on pure risk, insurance purchase, or maybe you're not even involved in that part. So that means you're still basic. Risk adverse, you're just responding, and risk seen in silos. So this is basically it. It's good for you to just have this discussion. This is another one. So for each one of them, there's a definition and the characteristics. So it's also good for you to discuss it with your team, each definition, and ask yourself, going through the characteristic, where do we fit? Are we naive? Organization unaware of the need for enterprise risk management? If you're finding people not knowing the difference between both or resistant to ARM, then you're still naive. If your organization are aware of the benefits of the enterprise risk management, but have only just started, so if you just started the thing, then it's novice. And if you started already and have embedded ARM into business, but management efforts still required, so you're still building the infrastructure, you still need time, then you are normalized until hopefully you can get to the natural leading in your field. For people who like to use the term agile and those terms in general, I added also this additional one that can also translate the maturity of the risk management in a different way. Start from the ad hoc to the agile. Again, read each one of them, from the ad hoc, which is still reactive, to the agile, which means it's integrated approach to risk management across the business, and there's consistency. And I think that's another way of looking at it. If you're looking at resilience, people who likes to use these terms again, risk management is about resilience, because it's about how quick are you in standing up again after a shock that you receive. So if you don't stand up quickly, then put a question mark on the risk management program in your hospital, and go back and check what went wrong and how can we make it better. Remember when I told you it's about contingency plan? A lot of people think when I say contingency plan, they refer to the whole hospital contingency plan. No, I'm referring to every single risk. The common thing is people, whenever they identify a risk, they put a program in place or an action plan, long-term versus short-term action plan, remember? But when I ask them about, okay, what's your contingency plan? What do you mean? I mean, if that risk happened tomorrow, what will happen? Are we ready to face it? Then you'll find a pause. If that pause happened, then we're not resilient when it comes to that risk. Now let's go back to the jargon. I know that I jumped to a lot of advanced thing, but a lot of people may ask, okay, can you go back to the basics, the definitions, and so on? So I covered that over here. The definition of risk, again, it depends on what you're referring, which reference you're referring to, which model. If it's ISO or IRM or COSO, they have different definitions. So for ISO, for example, it's the effects of an uncertainty or on objectives. Note that an effect may be positive, negative. So they're very clear in their definition that the risk can be both or a deviation from the expected. Also, risk is often described by an event, a change in circumstances, or consequences. So what we learn from here is that maybe two terms. One is the risk in general is something that can be positive or negative. Something did not happen yet it can be something positive or negative, and it will be impacting my objective. This is very important, by the way. When you lead a team in identifying risk, in order to guide them and be systematic, link yourself to an objective. Otherwise, risk is around us everywhere. So leading yourself, guiding yourself by an objective will make you focused in your session. So always try to link it to your own objectives or to the hospital objectives. That will make you focus. You get the high priority risk first. I'm sure you've seen the term uncertainty. So this is a common term in risk management. They use it when you don't know whether that risk is something positive or negative. You're not certain yet, so you call it uncertain because that thing might end up in something negative, might end up in something positive. If it ended up in something negative, some people call it risk. If it ended up in something positive, some people call it opportunity, not a risk. So that's why they use the term uncertainty first. So whatever they identify at the beginning of any session, they call it uncertainty, and then the team together, they will decide these are the risks. I'm sure that if it goes something whether negative or positive, I want to focus on them. And the rest are more definitions for you to read from. I covered that part when I told you that risk can be an opportunity, and usually, and again, there is an open discussion about that part because it's something new, so they leave it to the higher management. So it's not up to you or in our level, for example, to decide on taking a huge risk because it's an opportunity. This is an opportunity risk group. I'm going to take it. Wallahi, it's not up to me or you. It might cause millions to the hospital or a huge amount of money, or it might impact the reputation of the hospital, which is also a risk. So the decisions of taking opportunity risk lies within the hands of the board or the higher management. This is the key. Especially at the beginning. Once you install a good program, then you can go ahead and go down and to the every division. Now, when we say risk assessment, I'm going to cover everything related to risk assessment here for you. The risk assessment in our language and risk management, and I need to clarify a few points because in quality and patient safety, we also use the term risk management, but in another way. So let me explain it. When I say risk assessment in risk management or in ARM, I mean to risk identification, risk analysis, risk evaluation. So I'm not saying all these three words, I'm referring to these three. So I just say risk assessment. Commonly used in quality and patient safety, that sometimes you go and conduct risk assessment for a new service opened, for example. They will ask quality and patient safety teams to go and do risk assessment. And that is a bit different. It's also one tool used for risk identification, by the way. Under risk identification here, under one, we do conduct risk assessment. What do we mean by it? When I say different, what did I mean by that? It's different because that when somebody asks me as a quality professional to go and conduct risk assessment for a new service opened, for example, or in certain area to evaluate the risk in that area, usually I go using a checklist. And in that checklist, I add a set of standards. So it's like usually a compliance to set of standards that we have. For the risk assessment, as you can see here from the slide, we're referring to something completely different. We're referring to a complete cycle from risk identification, analysis, and evaluation. So I'll be focusing now on risk identification. First, I would like to ask you, when you do risk identification, when you identify the risk in your area, how do you do that? What tools do you use? What sources do you refer to in order to identify the risk? In order to make sure that at the end of the session, yes, I did not miss anything, I have identified all the risks. It's an open-ended question, so you can just tell me in the name of the tool or the name of the source that you used. Did you start getting any answers from the people?
Yeah. Someone wrote risk matrix. Lines.
Risk matrix.
FME, yes. Incident report, KPIs.
Excellent. What else?
FMEA.
FMEA.
OVRs.
OVRs, correct.
Incidents.
Incidents, correct. Risk matrix is not accurate, by the way. Risk matrix, we use it for risk analysis.
Also SRS.
SRS, correct.
ESR.
ESR. All the accreditation reports. Yes, correct.
And some write decision tree.
Decision tree, correct.
Yes. Fishbone diagram.
Fishbone diagram, RCAs, correct.
Yeah. Focus group.
Focus groups, correct. I think we can stop here for the sake of time.
Yeah, it's great.
So I I tried to summarize everything that I've read in one slide. So I came up with around major 15 groups. One is internal or external review, audit reports. So if you have internal audit and who come and audit your areas, you can use that as a source for identifying risk in your area. Department, your own objectives, plans, policies, critical process. So when you start the discussion, let's say you did a brainstorming session. So you ask people, okay, let's go back to our objectives and take it one by one. Objective number one, what risk are we or we may face that will hinder us from reaching or achieving that objective? You can do the same with every plan, policy, and critical process. The accreditation report, as you mentioned, the strategy plan of the hospital, and the SWOT analysis. And I've highlighted that in red, in black, because you can use it not as historical information, because you can also conduct it during the session. So during the session of risk assessment, you can work on the SWOT analysis, and the results that you get is you can take out of it some of the risks that you might be facing. Historical risk event information like the SRS. I know you'll tell me, but these are incidents. How can we use it? Incidents is an excellent source, because incidents, what happens is that you can see the trending. I'm not talking about incident by incident. The trending of the incident can really help you evaluating how people responded. And if you see that there are gaps in the mitigation plan, it's an eye opener for you that it will happen again. And if it continue to happen, it means that this is a risk that you're still having. A lot of people think that just because it happened, it's not a risk. If, for example, patient falls, how come it's still there? You find it in the top 10 risk in a lot of excellent hospitals in the US. Why? Because if that risk have the potential to happen again in the future, then yes, it's a risk. You can always go back to the claims, litigation data, loss history, financial statements, compensation claims if you have access to. If not, then that's also an indicator whether you have a mature program or not, because you should have access. Committee, departmental staff meetings, even those meetings can really help you. The evaluation. Root cause analysis, RCA, FMEA, bow tie, which is new, very common in the risk management. I'm going to cover it today. The KPIs, the hospital scorecard, if you have one. Hospital risk universe, which is something I'm going to cover today. Risk register, if you have one, you can refer to it and build on it. I don't advise anyone to start from scratch. Customer satisfaction surveys. So if you have one already done, or if not, you can use surveys. Some people don't like meetings, so they send surveys to the staff and ask them to identify the risks and show them the guide, and they wait for the response. The complaints, questionnaires, brainstorming, and brainwriting. If you don't know what brainwriting is, it's similar to brainstorming. You're simply using Post-it. Instead of talking, they will simply put it down in writing and collect the Post-it. Why do we use that sometimes? Because especially if you're mixing a lot of people, you're not dividing them into groups. So you have people who are in the same group with their bosses, and that will really not encourage them to talk. So what you do is that use the Post-it at that time. The peer review, if you have any. If you have safety huddles, rounds, observations, if you want to identify, you can only go and observe. It might be also an eye opener for you. External research, and I'm going to show you how. You can use best practices or what others say about the hospital. A lot of people ask about what forms I should use when I run this discussion. Let's say I called for a meeting in my division or my department, and I want to guide the discussion of risk identification. There are multiple ways. I'm not advocating for this, by the way, but I liked it because it says here key objectives. I don't like the discussion when it's not guided. Usually guide your discussion with the objective, whether your own objective or the hospital objective. Otherwise, you will identify risk here and there. You need to be linked, so because this will help you prioritize or identify what matters first. And then with the discussion, you can take, okay, what are the potential outcomes, the best potential outcomes, the worst potential outcomes. And from there, you can get up with this list, the uncertainties. Remember, we said it's uncertainties first until you decide it's a risk. It comes with a negative or positive impact, and you decide which one you take from here. So I give you this as an example. As you can see here, it's always advisable that you identify who are the stakeholders and the resources needed. Now, I'm not going to go through this question, but it's a question for you. Do you know your risks? Yeah, some people may say yes, no, but my question for you, I know, mashallah, most of you are intelligent, but always leave a place for improvement. So always go back and check your knowledge. Check, because on a yearly basis, there are lots of references, and I added here for you just examples of what are considered the global risk for healthcare. Go and check them, and just ask yourself and ask your team, can we face something like that in our hospital or in my department? Yes or no? No, skip it, go to the next one, skip it to the next one until you go through them all. And I added here a lot of common examples. This is from ICRI, and this is another one from McKinsey. And you can go on, and the list goes on, but at least don't start from scratch. And it will tell the people, okay, these are considered risk, especially if it's something new. So go through them. And again, as I told you, just because of the time, and I want to make sure that I cover everything for you. So I added all this information for your knowledge. And don't start from scratch. If you have a risk register already built on it, some people think that every year we open a new page, and whatever done was last year, you close it. That doesn't happen. You carry over. It's not like incidents when you close them and that's it. No, the risk will continue to be there even if you have excellent controls. And I'm going to cover that later on for you. I previously mentioned this is one of the differences. Like if you studied COSO with ASHRM, you're not familiar with this term. We don't use that with the COSO. This is used in ISO. And this is one of the things I've learned when I started dealing with the others. So Risk Universe, it's a term called for a document that contain, the taxonomy for the incidents. It's the same thing, because you need to put a categorization for the risk. So otherwise they'll be all mixed together, and if the numbers increase, you cannot classify them. So it's like the taxonomy for us, it include the type, subtype, and everything, or category, subcategory. It's the same thing. So some people divide it into compliance, financial, operational, and so on. And some people have more than one, depend on the model you're using. If you're using COSO, they have different ways of looking at things. I think this is from COSO, if I'm not mistaken. So they divide it into technology, legal, operational, human resources, and so on. So remember, Risk Universe is when you try to classify, every risk must have a type. So it's like the taxonomy for risk. So it's a document that contains every single type of risk, type and subtype, with the definition, so people can read and make a decision. Yes, this is the title I should give. Another term we use is risk register. So if somebody said, do you have a risk register? It means a document that includes the details of every single risk you have, from the number, the risk identification number, very, what do you call it? A special number for every risk, the description of the risk, the analysis of the risk. When I say analysis, it means the rating, likelihood and impact, and the rating, the owner of the risk, who's owning that risk, which means that the department or the person who will be responsible to fix that risk, the mitigation plan, if you have any contingency plan, again, there is no one specific excellent report. You may not have contingency plan there on the risk register, for example. The progress on action, the status, the resources, you may add to that. But at least the most common terms, I've added it here for you. So it's a document that contains everything. With this, we finished the risk identification. For those who answered with the sources for risk identification, they said matrix. The matrix, we use it for risk analysis, not risk identification. In the matrix, this is it. I got it from the internet. You'll find hundreds and hundreds of models. Some of them are 5x5, some of them are more complex, less complex. It depends on what your board or executives will approve or what model you want to choose, COSO or ISO. The idea behind it is that it measures the impact and the probability or likelihood. When I say impact, it means how severe would the outcome be if the risk occurred. And you need to have definition for each. And again, from one hospital to another, it's different. That's why I didn't add it here. But once you decide, okay, you'll find that, for example, based on your definitions, it's here. Based on my definition, for example. And then you look at the likelihood. Sorry about that. Go back again. And then about the likelihood and ask yourself, what is the probability the risk will happen or might happen? And then based on your definition, because usually in every hospital, there is a definition for rare and likely, moderate. So you read it, see what fit, and you say, okay, severe, it was here, and moderate, severe, moderate, then the risk rating is 15. So why do we use it? Why do we have a matrix? The matrix, or sometimes they call it the heat map, is there to prioritize your risks. You'll end up with hundreds of risks. If that's the case, which one you should focus on first? There's no harm. Remember, with incidents, we deal with the harm, with the or the impact also. But here, we merely depend on the matrix. So you need to be very clear, and you need to test the tool whether it's working or not. So you can see here that it helps you to track even the risk over time. So here I'm going to introduce you very quickly to the most common terms used. We hear terms like inherent risk. What does it mean? It means this is risk in the absence of any direct or focused action. So once you identify the risk and you put it in your risk register and you calculate it and you find yourself that you are in the red zone off, which means that you need to act on it now. And then after that, you meet with a team and you put a mitigation plan and you start working on the implementation. So every time you implement something, that action is now a control that we have in place, like a defense mechanism. So that will happen. If you introduce more controls, it will make the probability of that risk to happen decrease, and it will decrease the rating of the risk as well. That's why you'll see that after introducing several action, now we have this, which we call residual risk. Actual residual risk is the risk remaining after management has been taken. And then you have also something that we advise people to do. It depends on the maturity of your program. You need, when you start and when you have the risk identified from the beginning, what's your target before the end of the year? Will you be able to go to the green zone from the beginning, from 1 year? Some people will tell you, no, you might take more than 1 year to do that. Here's another tool. It's similar to the RCA. We're very familiar with root cause analysis, but for risk management, I like this one. It's very commonly used also. It's called the bow tie. Why is it called bow tie? Because it looks like a bow tie, and it divides your response into two. Response controls, whatever you apply. Like, for example, here you find as a kitchen fire as an example. And then you'll find that whenever you put a mitigation plan, and once it's implemented, remember I told you if you put fire alarm, for example, and once it's implemented, yes, it's a control. But the question is, what kind of control? And if that's a reactive response, yes, it is, because fire alarm, it happens that it's after the fact. After the fire happens. So the fire alarm will not happen before the fact. So we call these response controls. And I wanted to focus because we talked about being proactive as well. So we need to put preventive controls, something that can detect it before it happens. And it mainly here we're talking about the maintenance, the supervision, and these are called preventative controls. That's why I'm presenting this for you, because it helps you evaluate your controls, whatever you've been working on. And really, if you're seeing yourself focusing on the reactive controls, okay, you will guide the team to work towards having more preventative controls as well. Again, it's a visual tool if you like it. Another area of challenge is people when they meet and put controls in place. Let's say you decided on certain actions under the mitigation plan. 1, 2, 3, 4. We'll put a policy in place, a training, we'll send a memo, and I rarely find people who evaluate whatever the action they are requesting or suggesting or recommending. And usually after 1 year, we find out one of the actions is really not feasible to implement. The other one, you don't get the budget to implement approved for the implementation, and there is continue happening, and it's not improving. We rarely try to evaluate. So here, similar to the clinical, by the way, we have a hierarchy of controls. Same thing with us for risk management. I'm going to show you another one example. We have preventive controls, detective controls, corrective controls, and one is called directive, which is like the memos, procedures, policies. Very common, right? You'll see that in the diagram here. It's not even there. Why? They didn't miss it. It's simply they don't believe in it. And unfortunately, this is one of the common actions that we usually take. So my advice to you is that I'm not saying it's wrong, but we need to combine them. Go and evaluate your mitigation plan before it's implemented and it became existing controls in the hospital. Evaluate them. Are they preventive, like password protection, or detective before the event happens, or corrective after the fact? The directive alone, like policies, training, memos, they're weak. You need to combine it with something else. In summary, the less you depend on humans, the better your mitigation plan. I think some of you are familiar with this. We use it's very commonly used in the clinical side. And again, similar to that, if you consider focusing on warning, admin control, and PPE, because you're depending on humans again. We studied human factor engineering, so you know that depending on humans, it's not really reliable. So you need to have more automation. You don't depend on them. Humans make mistakes. That's a fact. You cannot avoid it. So try to introduce more engineering controls, substitute the hazard, or eliminate it or avoid it. Just simply don't give the service. Last but not least, I know I exceeded the time, so just bear with me. I hope I'm sharing good information with you. Last is the KRIs. If you heard the term predictive analysis, it's similar. Or they might ask you, do you have metric measures to monitor your risk? Do you have key risk indicators, KRIs? Yes or no? Do you have them or not? So in order to find the answer, a lot of people sometimes say yes, but when we go through the slides, they will see that, oh, so it means that whatever I had was KPIs, for example, or maybe the message is not clear. I think this slide summarize it very well. The KRI, key risk indicator, is an early warning system. So let's take an example, and I found this very common. One of the KPIs is infection rate in the hospital, right? So what do you think is a good example for a KRI for the infection rate in the hospital? Infection rate is a KPI, and I want to put a KRI for that KPI. What should be the KRI? I found some hospitals put infection rate also under the KRI. It cannot be. Because if it's an early warning system, how would the infection rate alert me that the infection rate will increase? It will not. So what would be a good KRI for the infection rate? Maybe the supplies related KPI related to gloves, related to mask, because it is an early warning system because it will give you an early warning. So if the amount of the gloves or the quantities of the gloves impacted severely in the hospital, yes, definitely something happened with the infection rate in the hospital. Same thing with the gloves, same thing with anything related to supplies when it comes to infection rate. So you can, this is the link you should give. Here I'm saying predictive analytics, just the analysis of current and historical data elements to make predictions about future events and trends. KRI is leading factor or set of circumstances that may be correlated with or precursor of the occurrence on a specific risk. Yeah, there's the point. At times, changes in KPI performance also can serve as KRI. Examples could be an increase in hospital fall rate being identified as a KRI. I'll explain this further. Some people ask me patient falls. Is it a KPI or a KRI? Sometimes if people come to you and put you in the corner and say this, do this to you, you simply need more information to decide. So if that somebody put you in that situation, tell them it depends how you're using it. So for example, patient falls, how can I explain this? Yeah. Patient falls can be a KPI, and then, for example, the number of times the nurses, not the nurses, the patient, for example, if you found a lot of complaints or incidents about the alarm or the bell not working in the patient room, that can be your KRI. Because if that numbers increase, it's an indicator for you that yes, more patients might fall because they kept calling the nurses and they're not responding. And there's no way to communicate with the nurse. So again, it depends on how you use it. Patient falls, on the other hand, can be a KRI when a KRI if you're using the number of litigation against the hospital as a KPI. So for example, if you had one case of patient fall in the hospital, this is your KRI. Let's be prepared. There might be a case raised soon against the hospital because of this incident. So in this situation, it's a KRI for a bigger KPI, which is the number of falls related litigations. So it depends on how you use it. As simple as this. Types of KRIs, we have 3 types, depend on what you're looking at. So if you wanna use these examples, if you wanna focus on response controls, because some people ask me sometimes, okay, what shurug KPI, shall I put a KRI for everything? No, طبعا. You prioritize depending on where most of the problem happened, you discuss it as a team, and then you decide. If it's related to fire alarm, then you put what we call it response control. Under response control, you can put a KRI over here. Or if you're looking at the preventive controls that we have in place and you want to monitor them, then you can put KRIs over here for them, for the supervision and maintenance before, God forbid, something happened. Because remember, they're early warning system. So they help you identify before, God forbid, something happened and the risk materialize. Or it may be put here for the sources of risk. If you're looking at the sources from the beginning, you can put KRIs here. It depends on where you put it, but again, you don't have to follow this. You can simply have a discussion and agree what can be the best early warning KRIs for you. I'll just take a few minutes from your time because I know that a lot of people might be asking about the risk appetite, and I found this video for you. You can later on you can see the whole video online, but I just highlighted the main parts for you. Let me start.
So if we take a look at your organ,
can you hear me the voice?
Yeah.
Good.
Organization, over time, you're going to try to plot your performance. And that is going to occur in things that you currently have, things like budgets and operational plans and so forth. Now, as you lay down those plans, you're also thinking of what are the thresholds you can operate above and below that level, which you're going to be comfortable with. You're not going to do anything different. So in the risk world, we call those thresholds the risk appetite. The idea is this. If you go below this performance to a certain level, you're going to get anxious. Or even if I go above that to a certain level, it may occur problems. So even if you take a look at something like sales, where you'd normally think, gosh, there could never possibly be too many sales. If you think of the recent release of the iPhone and the iPad, the demand was so huge that it began to cause downstream problems. Both technical support and customer service were unable to deal with the volume of business that was suddenly coming their way. So even a high value can be bad. Again, the risk appetite. Now, above that, there are performance levels that are going to cause even more grief. So at a certain level, it's going to be beyond what your organization can easily accommodate. You might now need to have special meetings, allocate resources, launch special projects, and so forth, both above and below the current performance levels. In the risk world, we call that the risk tolerance. And the idea is those are areas where the performance goes beyond what the organization can seamlessly absorb and special efforts need to be taken. Now, obviously, there's lines even above and below that. So that line where, as many good things that could possibly happen actually occur, but of course, the opposite. What if everything bad could possibly happen as bad as it could occur? In the risk world, we call that the risk universe. And that's the total possible spectrum of what could occur in your business environment. So if you're doing a plan, that current performance is sort of your target. In this example, let's say we're planning to have 5,000 customers. Now, as you're planning, you might go, well, so long as customers are above 4,700 and below 5,600, we're okay. That's within tolerance of our business performance. That's called the risk appetite. Now, above that is what we call risk tolerance. So you might say, gosh, if we get fewer than 3,500 or over 7,000, we have to take drastic action, maybe as severe as leaving the market as an example. And that's, of course, the risk tolerance. So how do we deal with that? Well, traditionally in your business planning, the stuff that you call target, if you think of, say, a scorecard or dashboard where your indicator turns red, yellow, and green, green, you're meeting expectations, yellow, you're slightly off, and red, it's a crisis and we need to take special action. Target would be green. So effectively, that area called risk appetite is where we have our green measures. Risk appetite really is the yellow. It's within tolerance. We need to pay attention to it, but we're not going to take any heroic activity. That's the yellow band. And then finally, risk tolerance. That's what happens if it's a severe issue and it's all hands on deck. We need to solve this problem. And that's the red band. So what we're seeing is the traditional red, yellow, green bands. What does that mean as we compare and connect the risk thinking with the performance thinking? Well, two things. First, determining the process performance levels is obviously owned by the organization, the process owners and leadership. And these targets are going to inform us of the risk level, appetite, and tolerance. In other words, if you want to sort out your organization's risk appetite and tolerance, you actually have to start off with the processes. Understand how those processes link back to the strategic objectives and the risk elements, and from that, you can determine the performance levels that your current resources allow you to generate, and from that, where your red, yellow, green risk appetite performance levels should be.
And the message from this, because a lot of people ask, how can we determine the risk appetite and risk tolerance? So you treat them exactly the way you treat the KPIs in the hospital. Who determine the values for the KPIs? Usually the higher management. Deal with it in the same exercise. You take them through every single risk and you sit with them to determine the value for the risk appetite, whatever you want to accept, which risk you can accept. So which one you see the target, and I think the way they explained it here, very simple for you. So you just go through the same with the leaders to determine the values, what should be accepted under risk appetite, risk tolerance, and so on. And you'll be in the safe side. I think this is the easiest way to look at.
So if we take a look at your organization.
Sorry. Okay. This is the last part. And again, by the way, for the risk appetite and risk tolerance, you may adjust. So especially if you're at the beginning, take it similar to the performance management. Take it and you may go back and revisit it again, let's say every quarter, every 6 months, and make certain adjust it or tweak it until it fits your organization. So trial and error until you get it right in your hospital. I'll leave you with this takeaway message, and I have a point behind this video. So let's watch it very quickly. This is just a trailer for a movie. I'm not advocating for it, but there's a message behind it. Let's watch it together.
After we survived Hurricane Katrina, we thought that we could survive anything. And we were wrong.
They found 45 dead bodies there. Now, does that make any sense to you? I'm under a great deal of pressure to look into what happened.
There were 5 days, the most ungodly conditions.
We are getting all of these patients out of here. We are nurses, and we're gonna get it done.
As long as we don't get left behind. We have to be realistic about the situation.
There is nothing else to do for them except to make them comfortable.
So what are we talking about?
They asked me to look into the deaths at Memorial Medical Center.
The Attorney General's office is focusing their investigation on you.
They're suggesting that some of their patients' lives may have been ended.
I am sure that patients do not suffer pain.
Some people were afraid of people outside of the hospital, but for me, it was the other way around.
If you were given a choice between comforting a patient, possibly quickening his death, or abandoning patients to suffer a slow death, what would you choose to do?
Say goodbye! Come on, man! Stay back!
All I did was try to help people. That is all I did.
Okay, now people will ask me, why did I put this? I learned a lot from this video. I'll tell you the story. A few months back, my husband came to me and told me, do you want to watch this movie, 5 Days at the Memorial? I told him, what is it about? He told me about Hurricane Katrina. I told him, oh, now, after all these years, they came up with a movie. And of course, similar to any patient safety or risk officer, I thought that I knew everything about it. I knew the root causes of the problem, the fact that they didn't have a contingency plan. So what's the point of watching that movie? And the lesson I learned that I need, and again, if I'm like that, I'm sure a lot of people are like that, we need to be open to review and be open to listen and learn from other people's experiences. We always tend sometimes because of our experience, because of our position in certain organizations that we know the best, or sometimes people like to listen to certain organizations like international well-recognized institutes. But if it from a national hospital, we might be resistant to do that. So I learned to be open, because one of the major things that I realized was like somebody slapped me on the face, that the movie did not talk about the contributing factors or the root causes that I knew. I thought that the people in the trailer you've seen 45 people died. Why do you think they died? Is it because the fact the hospital didn't have a contingency plan for flood? Nope, that was not the case. Yes, the hospital did not have a contingency plan for flood because it never happened in the hospital, in the area. They had it's not a bad hospital. They had a contingency plan for everything except for flood, because it never happened before. But again, people did not die because of that. Actually, these episodes, it's not a movie, sorry, it's a limited series. I think 6 or 8 episodes. And they only talked about what I knew in the first 2 episodes. The rest of the movie, and that's what was really touchy, it was really emotional for me, because they talked about the ethical dilemmas that they went through. And I didn't know before this, before watching this, that they were really isolated from the world. People, including the government, thought that the hospital was evacuated already. So nobody was looking, searching for what's really happening in the hospital. So they struggled for 5 days. No contact whatsoever. No electricity. So, you know, for the clinical people, do you know what that means? No ventilators. They're ambu bagging every single patient. So the nurses were tired. Limited resources, water supply. So they reached a stage where they had to fight for a bottle of water. We are holding knives in the hospital. So the question that I was thinking is, our contingency plan put into consideration the ethical dilemmas like that? They were afraid to leave the hospital and go outside, even to smoke, because maybe they cannot return. Theft, killing happening because the whole city was impacting. Harassment, sexual abuse, everything was happening. Are we ready? And then another thing, that people, because they were struggling outside, they wanted to come inside the hospital for shelter, but they had already limited resources. They only a few bottles left, and it was really hot. So shall we accept people from outside? We cannot do anything for them. So they started pushing people away, to the fact that to a limit where you can see in the if you watch it, they had to use guns to stop people from going inside. And not only that, going back to the 45 people who died, they reached the stage when the National Guard came. After 5 days, they told them, okay, we have only 5 hours. We have limited numbers of boats and helicopters, but we cannot save everyone. You need to choose. Based on what? Choose. And usually we tend to look at maybe, okay, the DNRs first, and then what? What's your second? Because you need to leave more people behind. Based on what? Do we have like this checklist that can help me? There is nothing in place. So it was really difficult for them. And if leaving them, they're not on working normal environment. No, I have to leave the patient because I'm ambu bagging myself, which means I have to leave the ambu bag, leave the patient suffer. So the physicians had to make a decision to kill the patients. Softly, I should say. They thought that they will suffer less if they did it this way. But what happened after the fact? Everybody was investigated. They killed in their eyes, they killed those 45 patients. So it was really, you're talking about ethical dilemmas, but it's an eye-opener in the same time. Yani, it's always, when you look at the implementation of ERM in banks and other well-established, where ERM is well-established, they have softwares that can help them run worst-case scenario. I learned that theoretically. But now I understand why is it so important. When you put an excellent mitigation plan and you implement it in banks, usually for every risk, the system will run bad scenarios, a lot of hundreds of scenarios. Why? Because they want to test whether you're ready for that risk or not. We don't do that. So did you try to run scenarios like that? Try to test it wherever let's say that you've done with the risk, you have an excellent mitigation plan. And usually they teach you to bring, for example, I'm an optimist by nature, so I'm not good in this. So they ask you to bring the people who are pessimist. You know, those kind of people that sometimes you find them in your department, or you know them, that they're negative. They like to pick on the negative things. Whether you like them or not, they're good in this part. Bring them in and tell them, criticize my plan and find what's wrong with it, because that's what you want in risk management. I think that's something we should learn to do. because we don't have softwares like banks that can run different negative scenarios for us. So we need to do it ourselves. Bring the pessimistic people in your teams to help you. So that's it. I wanted just to leave you with a message from the heart. It's the end of the discussion.
This is part of disaster management, also how to deal with the crisis. And we learned from you a lot today. And business continuity is a part also to deal with the crisis, such you mentioned, and answering 5 questions: what should be done, when should be done, what is the alternative resources, how to get these resources, how to communicate. All of this is it's one of the parts of contingency plan, as you mentioned. Thank you, Mrs. Shorouk, Zakaria, for addressing valuable, interesting topic. And now the questions right now. Our participant, you can post your question in the Q&A icon, and Mrs. Zakaria will answer your question. And if you allow me, there is questions wrote in the chat. Someone asked about what is the difference between issue and risk.
Okay, this is also a good question, and usually people ask about it, and we find it one of the common mistakes that something happens, especially at the beginning, because we advise them to report all the risk, and we don't stop them. You have to be careful. If it's an issue, don't report it, because we wanted to take it with them step by step. So yes, we found people who report issues, and then we went back again to them and explained to them a risk is something that did not happen yet. It might happen, and you can even don't know the consequence, whether it's something negative or positive. But an issue is something that happened already. But in the same time, before rejecting the issue, we usually listen to them, because sometimes with the discussion, we discovered the risk that they wanted to write, but they just didn't know how to write it. So we usually, before taking it out from the risk register, we ask them about why do you think it's a risk? Give me more details, how it happened, what's the problem in your area? And then they explain to us all the details, the root cause and everything. So we find out, yes, a more common risk that covers the umbrella for different issues that happening in the area. So we usually rephrase it in the risk register. So in summary, risk, something that did not happen yet. It didn't happen. It might happen in the future, and we help them identify or put an action plan for it. If it happened, then it's an issue. If it had, for clinical, it might be confusing a little bit, because even until now in the US, you'll find more in the top 10 risks that they had. For us, they were considered like incidents, like patient falls, pressure ulcers. They consider it in the top list for risks. And their justification is that, and a lot of people, even in banks, we double checked with them, if that risk, if that incident have the probability of happening again in the future, because maybe the mitigation plan was not put right, then yes, we consider it as a risk and we keep it in the risk register.
Thank you. Thank you, Mr. Zakaria. I think we exceed the time. It's now more than the time of our session. On behalf of the Saudi Patient Safety Center, we would like to thank you, Mrs. Zakaria, Shorouk Zakaria, and our audience for the active presentation and valuable knowledge that you provided today. As a part of Saudi Patient Safety Center, effort to provide you timely topics and interesting speakers, we appreciate it if you would fill out the evaluation from our participant survey that sent your email after this session. Thank you for joining us today, and we will look forward to welcome you back in future webinars.